Good morning, everybody. I'm going to review the Academy chapter on retinal vascular diseases associated with systemic cardiovascular disease. And I hope you'll interrupt me if you have any questions during the talk. It's difficult with Zoom, but I think we can make it work. So let's take a look here and see how we go. Okay. Good. So this is a list of the topics that we'll cover in the talk today. I'm going to try to keep it at about 45 minutes to keep on schedule. Let's start with talking about hypertensive retinopathy. You can think of it in terms of acute and chronic changes that you get as a result of systemic hypertension. There are a number of scales and stages that have been described, including the Keith Waggoner-Barker. But I think it's helpful to think of it in terms of what you see acutely and then what you may see chronically. Acutely, focal arteriolar attenuation is something that's important to pick up on because it's fairly classic for acute hypertension, but generalized constriction is also seen due to autoregulation of the retinal vessels. Now, focal intraretinal periarteriolar transudates, or FIPS, was described by Hayray. If you search that, there's only 4 articles in the entire literature. They were written in the late 1980s. They were all by Hayray. And so there's very little outside of his original coining this term, but we'll talk about it. FIPS look like small cotton wool patches, but Hayray distinguishes them from cotton wool patches in that they're smaller, they're less white, they're periarteriolar in distribution, they're deeper in the retina. They don't evolve into cotton wool patches over time. They go away over a period of a week or two as opposed to a month or two for cotton wool patches. And he felt they actually represented transudation from the periarteriolar bed. They're diagnosed most readily on fluorescein angiogram as little hyperfluorescent spots next to the arterioles. And so FIPS is something that was covered by your book. You're familiar with cotton wool patches and retinal hemorrhages. They tend to be flame-shaped when in an acute phase, and then as the hypertension resolves, they become more blot, and then they, of course, disappear. Chronic changes are difficult to categorize because there's usually concomitant hyperlipidemia, diabetes, tobacco use, aging changes that can make the findings more difficult to specify that they're due just to hypertension. But generalized arterial sclerosis, AV crossing changes are often cited. If you see exudates and such as that, I think you need to at least look for complications like vein occlusions and such as that. So here's a case of acute hypertension, and I want to bring your attention to this little arteriola here. It looks like it almost just pinches off, and this is what would be considered focal arteriolar attenuation. There's generalized changes as well. You see a few little blot hemorrhages. This patient did not have severe hypertension, but did have hypertensive retinopathy. Here's a little cotton wool patch, or one might argue it's a FIP, and a fluorescein would distinguish between the two. But here's a nice photograph of a patient with typical hypertensive retinopathy. You see the hemorrhages, the cotton wool patches. Now the cotton wool patches here, they tend to be larger. These smaller white things here would be considered FIPS. And they can be seen nicely on this red-free photograph here, the little FIPS next to the arteriole. And there are other small FIPS here as well. If you look at the fluorescein angiogram over on the right, notice the cotton wool patch is hypoautofluorescent, whereas the FIPS tend to be hyperfluorescent, little focal hyperfluorescent spots. And that was one important distinction that Hayray makes in determining the difference between the two. He felt that FIPS were fairly typical for hypertension, but I wonder whether that's true. And now with OCT, which he did not have at the time, it may be that FIPS falls into this PAM category as well, or at least there may be some overlap. Now, we talked about retinopathy. We like to think of different areas that the hypertension can affect. It can affect the choroid, and we'll talk about optic neuropathy as well. Hypertensive coridopathy is usually not seen in isolation. That is, it's usually seen with hypertensive retinopathy. The retinopathy usually is seen first. You can get lobular occlusion of the choriocapillaris, And with this, you get some degree of outer retinal opacification, but it can be fairly subtle. And in acute hypertension with all the retinal hemorrhages and cotton wool patches, they can often be overlooked. There's probably no critical reason to identify acute hypertensive coridopathy because you'll identify the retinopathy, but be aware that it's there. In the periphery, you can get wedge-shaped patches of opacification due to occlusion, especially in pregnancy. RPE detachments, serous retinal detachment is seen. Now, chronically, you'll just get the RPE clumping and atrophy in the distribution of the occlusion. We'll talk about that a little bit more with some photographs. So here is from an article I borrowed for the acute hypertensive. You see a cotton wool patch here on the photograph, and then next to it, little focal areas of RPE elevation with a little bit of subretinal fluid leakage too. But mainly on the ICG is where you're going to see a little hypofluorescent spots in the choroid indicating hypertensive coridopathy. When we see a patient with hypertension and we have hypertensive retinopathy, generally we don't do ICGA, but if you did, you would pick up acute coridopathy in many of these severe cases. Now, there are some signs that there's a trend away from named problems like Segrest, Amalric, and Elschnig, but it's helpful to know if nothing else for historic reasons. And these are chronic changes. Here you have some acute hypertensive retinopathy, but then you get this linear area where you get an opacification of one of the arterioles in the choroid, not the retina. And if you look carefully, it's hard to see there's little overlying pigmentary clumping over this, and that's considered a Segrest streak due to an occlusive area of a choroidal vessel. And if you get the long posterior ciliary artery occluded, you'll get this triangular Amalric sign with pigmentary clumping. Some people will say, well, this is a series of Segrest streaks, and I guess it depends upon which name you want to use. But posteriorly, you'll get lobular occlusion of the choriocapillaris. So some of these patients, after the acute episode is resolved, you'll see little areas of focal RPE clumping referred to as Elschnig spots. Now, neuropathy is often seen along with choroidopathy. And again, in an acute phase of acute hypertensive optic neuropathy, you'll get hypertensive changes. So it's generally not a puzzle as to what's the cause of the optic neuropathy. Acutely, you'll get disc edema, flame hemorrhages, exudates, and then you can get a secondary dilation of the venous tree just due to the disc edema. And there's a differential diagnosis. Hayray considers hypertensive optic neuropathy a type of ischemic optic neuropathy and sort of gradations thereof. But of course, there is the ION, arteritic and non-arteritic. Diabetic papillopathy is often considered a type of ischemic optic neuropathy related to diabetes. Radiation is certainly ischemic as well in terms of general categories. Neuroretinitis can be confused with hypertensive optic neuropathy. So if you see a case of optic disc edema and a star, a macular star, don't jump right to neuroretinitis. Don't forget hypertension can cause that. This is a case of mine who had significant optic disc pallor after an acute severe episode of hypertension, which is now gone. He had exudates in the macula, a little star figure that's almost gone. And here's a nice classic case of optic neuropathy with disc edema. Again, I don't think you would have too much of a problem diagnosing this as being from hypertension with all these other changes. It isn't just optic disc edema in itself. You get other associated retinopathy that clues you in to hypertension. So in that regard, if you have a patient who just has disc edema and the macular star, and you're thinking, well, this looks like neuroretinitis, and you're missing all of these other features, it isn't a bad idea to check the blood pressure, but it's not likely going to be hypertensive optic neuropathy. So we'll move on to retinal vein occlusions. Retinal vein occlusions are related to a thrombosis in the vein, and the thrombosis in the. Did somebody ask me something? Okay. the thrombosis in the vein is felt to be due to turbulence in the vein that can occur at AV crossings. So you can get this, they can affect the macula, it can affect a major vein in the supratemporal or infratemporal. It can be extramacular, not even involve the macula at all. Or if it's a branch vein, it's an AV crossing near the disc, it can affect the superior or inferior hemisphere, but it's considered a branch vein occlusion. Now, you can also get turbulent flow due to bowing of the lamina cribrosa in glaucoma and glaucoma suspect patients. So that's another site of vein thrombosis, in which case you have a central vein occlusion or hemicentral. Hemispheric is at AV crossing, no disc edema. Hemicentral is at the lamina cribrosa and you get disc edema, an important distinguishing factor in terms of etiology. When it's at the lamina cribrosa, you're thinking about possible underlying glaucoma. Risk factors: arterial sclerosis, of course, due to the AV crossing changes, glaucoma in patients with vein occlusion or hemicentral. And then if you have a young patient who has a vein occlusion, you have to think about hypercoagulability, and we'll talk more about that later. It's worth mentioning that despite the fact that vein occlusions are felt to be thrombotic in etiology, anticoagulation generally is not recommended because it may worsen the hemorrhage and result in some permanent macular damage. Along this line too, when you have these patients and you're dealing with their internist, I found that it's important to point out to the internist that when you send the patient in to get general vascular testing, they don't know that the vein occlusions are not due to emboli. So they'll often check these patients for sources of emboli, and it's important to indicate to them this is not an embolic disease. Now, branch retinal vein, including hemispheric, again, we talked about the AV crossing changes. There is an exception in that inflammation can cause a vein occlusion. Like you can get a peripheral vein occlusion due to toxoplasma retinitis, for example. So that's an exception to the AV crossing. So if you see a vein occlusion and the site of occlusion is not at an AV crossing and it's a branch vein occlusion, you got to think about something else. Something else may be going on. You're familiar with the acute quadrantic hemorrhages that you see in vein occlusion. You may or may not have cotton wool patches. You're looking on the fluorescein for capillary dropout, which could increase the risk of complications of neovascularization. You may or may not have macular edema that would require treatment. And then in the late phases, you'll have no hemorrhages. You may have sheathing of the vessels. So if you see sheathing and attenuation of the veins and the artery in the supratemporal quadrant, a lot of people think, oh, this might have been an old artery occlusion. It's usually a vein occlusion when you see that kind of sheathing. You may have some persistent edema. You may have exudates, and of course, complications of neovascularization, which might fibrose. You might have tears and detachments, vitreous hemorrhage as a result of that. So here's a couple examples. Now on your left-hand side, you see this quadrantic distribution of retinal hemorrhage. Notice that it doesn't cross the horizontal raphe. That's anytime you see hemorrhages that are isolated and they don't cross the raphe, you're always thinking of a branch vein occlusion. The fluorescein angiogram shows some blockage from the hemorrhage. You can't say definitively how much capillary dropout there is, though there probably is some. The hemorrhage is blocked, and acutely it can be difficult to determine the degree of capillary dropout in a vein occlusion. And this side over here, you have a similar quadrantic area of retinal hemorrhages. You have some cotton wool patches, and on the fluorescein angiogram, it looks somewhat more convincing of capillary dropout. So you're going to be more on the lookout of neovascular complications. Here's a late case of vein occlusion. You can see some sheathing and ghost vessels along the supratemporal arcade from this old vein occlusion. And as a result of the capillary dropout, you have disc neovascularization and vitreous hemorrhage. And there's the neovascularization on the fluorescein angiogram. So how do you treat branch retinal vein occlusion? Well, it depends upon what complications that you are dealing with. Most commonly, you're going to have macular edema accounting for decreased vision. And the standard treatment nowadays for macular edema in this situation is anti-VEGF therapy. And there are a number of studies that show the value of anti-VEGF therapy promptly instituted for best results. Steroids show that they can be a benefit. The SCORE study showed that the intravitreal triamcinolone, it was more or less equivalent to grid focal laser, but there were steroid complications, cataract, glaucoma, so it makes it less appealing as a first-line treatment. There is still a role, in my opinion at least, for focal macular laser in some of these cases, particularly if protracted need for treatment with anti-VEGF is required. Sometimes you can have a few focal areas that you can safely and lightly treat and resolve the edema and eliminate the injections. If you have pre-retinal neovascularization, scatter laser in the quadrant of the capillary dropout is helpful. If you have vitreous hemorrhage, if it obscures the view, then we'll initially use anti-VEGFs to let the hemorrhage clear and then use laser. But if the hemorrhage does not clear or you see complications on the ultrasound like retinal detachment, then vitrectomy would be the course of action. Now, when we discuss central retinal vein occlusion, it's important to think of it in terms of is it a non-ischemic or is it ischemic? Because the prognosis is significantly different. The single most important factor in determining this is non-perfusion on the fluorescein angiogram. And if it's less than 10 disc areas of non-perfusion, generally it's non-ischemic. If it's greater, it's ischemic. In general, the vision will be better if it's non-ischemic. There won't be an afferent pupillary defect. Visual fields tend to be normal in non-ischemic. Retinal hemorrhages seem to be milder in non-ischemic. And cotton wool patches aren't as prominent a feature. Not many people do ERGs, but if you did, you could notice decreased amplitude of the B wave on ischemic vein occlusions, indicative of intraretinal damage from ischemia. And then, of course, here is the important thing. They both get macular edema or may have macular edema, but you get neovascular complications from the ischemic vein occlusions. And that's the importance of identifying and monitor them carefully. Remember that about a third of non-ischemic cases convert to ischemic vein occlusion over 3 years. So once you make your initial assessment, don't rest on your laurels. Keep an eye out if the picture changes, if the acuity starts to drop, or if you start to develop other signs of ischemia, an afferent pupillary defect. Watch carefully for complications. So here we have some photographs of central vein occlusion. I wanted to demonstrate the flame hemorrhages that you tend to get in central vein occlusion. You can get cotton wool patches such as this. In the early stages, you don't get exudates. They'll come on in the later phases here. On this case down here, you get the hemorrhages. You get disc edema as well. But here you don't have as many cotton wool patches, so that varies. On this fluorescein angiogram, you can see some peripheral capillary dropout. And then, of course, that's the hyperpermeability of the retinal vessels as well. What do we have here? Anybody want to comment on this white area here? Just let me know you're out there.
It looks like possibly ischemic retina.
You're right, that's exactly right. So here we have some cotton wool patches, but here you have this patchy area of ischemic retina. Anybody have any idea of why this is present? Because this is sometimes seen in concert with central retinal vein occlusion. The venous stasis, the blood flow outstrips the arterial supply to the retina. So you get what looks like a branch artery occlusion, but what is this actually? It's not a branch artery occlusion.
The ciliary retinal artery.
Yes, thank you, Sarah. That's exactly right. So you can get a ciliary retinal artery occlusion in the presence of a central vein occlusion. That's well described. What have we here? Anybody?
Looks like some neovascularization.
Thanks, Brad. That's exactly right.
Oh.
Well, excuse me. This resembles disc neovascularization, but notice Notice that these vessels look, they're looped, they're sort of looped around, they're large caliber, they're not fine, they're not fibrillar. So this is actually an example of optic disc collaterals. And so in a late case of vein occlusion, often, but not always, you'll get optic disc collaterals, and they have to be distinguished from disc neovascularization. If you're in doubt, you could do a fluorescein angiogram. As you see more and more of these, you can look at them and determine that they're disc collaterals. Remember from previous talks that if you have a patient that just comes in with disc collaterals, no history of a vein occlusion, no evidence of a vein occlusion, you got to think of other problems that can cause venous stasis, like meningioma, glioma, such as that. So don't always just immediately rack this up to an old central vein occlusion. So here we have an interesting case. First of all, this is a little area of neovascularization from capillary dropout. What are these big sort of vertically oriented vascular channels? Anybody? I'll give you a little hint. This patient had an inferior hemicentral retinal vein occlusion. That's why the inferior retina is affected, but the superior retina looks pretty normal. So what are these channels?
Yes, those are collaterals as well.
Exactly. And they go across the raphe. And that can be real helpful. Sometimes you'll have a patient that comes in and all the hemorrhages are gone and you can't really see much clue of a previous vein occlusion, but you'll find these collaterals across the raphe. And whenever you see collaterals across the raphe, with very rare exception, it means that there was a previous branch vein occlusion or hemicentral vein occlusion. Now, why did I put no? These are pictures I downloaded from the Academy, and this was listed as a central vein occlusion. I'm kind of lightly objecting to this category. Why don't I like this diagnosis of central vein occlusion? Anybody?
There's no peripheral hemorrhage.
Yeah, you don't see any hemorrhage out here. There is some venous stasis. You can see some dilation and tortuosity of the veins, but there's a lot of posterior involvement here. And this could be classified perhaps as a central vein occlusion, but my reason for putting it in here for you is that when you see something like this where it's primarily around the disc, you've got to think of a disc infiltration of the disc, inflammatory, neoplastic, and such as that, because or retrobulbar pathology, because this is more a posterior sort of peripapillary presentation. In young people, sometimes you can get something like this, and it's referred to as Papillophobitis once you've ruled out other pathology. But when you see something like that, you've got to think about other diagnoses. Don't jump right into vein occlusion. In fact, here, speaking of Papillophobitis, that's a term used by some in the literature for basically for a central retinal vein occlusion occurring in a younger patient. And it, generally speaking, in younger patients, vein occlusions or Papillophobitis do well. They develop symptoms, it clears up, and they get a full recovery, and they do just fine. However, you've got to consider underlying coagulopathies in these patients and inquire about contraceptives, test as needed. These are the tests that I'll often use looking for coagulopathies in younger patients. So keep that in mind. Although the natural history is often fine, often these tests are negative, you've got to think about underlying problems. How do you treat central vein occlusion? Well, for macular edema associated with central vein occlusion, anti-VEGF is the mainstay. And there are a number of studies showing the benefit of anti-VEGF. Triamcinolone can be used as well, intravitreal. The SCORE study showed that. It was better than observation alone. The dexamethasone implant is helpful, has 60-day peak effect by the Geneva study. However, the COMRADE study showed that ranibizumab had a better long-term acuity. So it's sort of a second-line treatment for macular edema and central vein occlusion. Another reason why I'm not as fond of steroids in central vein occlusion is because these patients often have underlying glaucoma or at risk of getting glaucoma because they had the occlusion at the lamina cribrosa, and so they may be at high risk of complications. The CVO study showed that macular laser is not effective for macular edema in central vein occlusion. And PRP laser is basically effective after you have neovascularization, after it's been documented. Though there have been some recent studies that question that. And I think there are patients who have severe ischemia who are at so high risk of developing neovascular complications, and their acuity is poor, that it's reasonable to treat those patients. Explaining, of course, to them that you're not treating to make the vision better, you're just trying to keep the eye from becoming blind and painful. All right, neovascularization. My picture didn't turn out too good, but here's a case of iris neovascularization, or old-fashioned name rubiosis. It occurs in about 60% of ischemic central vein occlusions, not all. It used to be called 90-day glaucoma because that was about the peak time that they would show up with glaucoma in the older days. And it was a very severe type of glaucoma that often resulted in enucleation, which is now usually avoided. Keep in mind that the onset of iris neovascularization is delayed with anti-VEGF therapy. So if you have a patient and you're treating them with anti-VEGF and then their macular edema slowly resolves and you start tapering off, and maybe let's say you get to the point where you say, okay, we can stop the anti-VEGF before the point for the onset of iris neovascularization. And they should be checked probably monthly or close to monthly for 3 to 6 months, looking for iris new vessels before you relax on that. Now this is important. New vessels that form iris anterior chamber neovascularization occurs in the angle often before you see it at the pupil. Now this is different from diabetes and from other situations, and that's critical. What that means to you is when these patients come in for follow-up, you've got to do gonioscopy. You're going to miss the angle neovascularization. It's going to come on way before the pupil, and in fact they'll present with pressure problems sometimes much when the pupil looks pretty good. Got to do gonioscopy. Why is it that the superior angle is involved first? The senior residents probably know this. Chime in. Please.
I'm not sure.
Okay.
Maybe it has to do with the flow of the aqueous.
That's right. There's a convection current in the anterior chamber. The cornea is cool and the iris is warm. So the convection currents bring the aqueous fluid up against the iris into the angle, so the neovascular, the VEGF causes new vessels superiorly. So if you have a patient who's not very cooperative and you're going to only get a quick look at the angle, the first place you want to look is superior. If you don't have angles in the superior angle, you're not likely going to have vessels elsewhere. Now, this convection current that we mentioned is also the reason that you get that triangular pattern of keratic precipitates, the so-called Arlt's triangle. That also has to do with the convection currents in the anterior chamber. Okay, so generally, if you have a patient that comes in with iris new vessels, their pressure's up or it's going up, you need to get a quick, effective treatment. So usually you'll give an anti-VEGF injection, then schedule them for laser. Good. So, and then of course, if you have a dense vitreous hemorrhage that doesn't clear, you can consider vitrectomy. A glaucoma ceton is often placed at that time if the angle is zipped up. So the differential diagnosis of central vein occlusion includes hyperviscosity. It's going to be usually bilateral. You're not going to get a unilateral central vein occlusion and have Waldenstroms, for example. Ocular ischemic syndrome can mimic it, but the peripheral hemorrhages tend to be much more prominent, and you tend not to get optic disc edema in ocular ischemic syndrome. So that separates that. But always remember that anything that causes optic disc edema or anything that can cause a backup of the blood flow, like cavernous sinus thrombosis, can simulate central vein occlusion. So keep those things in mind when you're seeing these patients. If there's no questions on venous occlusive disease, we'll switch over to the arterial tree. Anybody?
I have a question, Father. We had a patient in clinic yesterday who presented with his second hemi-retinal vein occlusion, the inferior aspect of the retina as opposed to the superior aspect previously. Would you get a coagulability workup in that patient?
That's a good
Despite
question.
having hypertension as a risk factor?
You said the patient did have hypertension?
Correct.
And you said you skillfully used the word hemiretinal. Can you say whether it's hemispheric or hemicentral?
Hemicentral.
Hemicentral. Okay, good. So hemicentral immediately means that the occlusion occurred at the lamina cribrosa. So the first thing I would think about is, does this patient have an underlying predisposition to glaucoma? Does the pressure pop up at times? Because that could cause the onset of a vein occlusion. Did your patient have any personal or family history of glaucoma?
No personal history, and I don't think a family history. We didn't ask
Oh,
personally, but
that's
I
fine.
doubt he's.
And the disc, was there a lot of cupping, or what did the cup to disc look like in the other eye or in that eye?
Yeah, normal cup to disc, no signs of glaucoma.
Okay, good. So that's the first thing I would think. And then the second thing, when I'm thinking about coagulopathies, I would think about, well, what's the age of the patient? How old was your patient about?
In their 50s.
Yeah, okay, so that's right around the plus or minus. And I'm sorry, you said this patient had hypertension, but that was all?
Correct, and he reported that it was controlled with medicine.
Okay, good. So if you get the sense that he's had fairly well controlled hypertension, no bad history of lack of treatment and such as that, and perhaps if there's not a strong history of retinal vascular disease in his parents, indicative of pre-senile arterial or sclerotic vascular disease, then I would start thinking about coagulopathies. Another thing I would look for in those patients is to see what the AV crossing looks like. If there's a lot of AV nicking and such as that, then I would tend to strike it more to the hypertension. But if not, then I think that would be perfectly fine to work that patient up for coagulopathy. Probably I wouldn't look so much for the congenital problems like protein S, protein C, antithrombin 3, but I might look for other things like hyperhomocystinemia and such as that. So I think a limited workup would not be unreasonable. Others might not do anything, and I wouldn't fault them for that. I probably would do a limited workup at that point.
Thank you.
Yeah, thank you. Great question. Anybody else?
So I typically will order homocysteine levels just because it's easy to do and it's easy to treat. So, you know, even if I'm not really looking for a coagulopathy and they may have other risk factors, I typically will order a homocysteine level as well.
Yeah, I have a low threshold. I agree. Thanks, Karina. Anybody else have an interesting case or a question on those topics?
Something interesting that happened with one of the consults at Tampa General for me, but it also ties into arterial occlusive disease. So I was thinking of waiting till after that, but basically we were consulted just for a transplant evaluation. Anybody who's undergoing a solid organ transplant, you know, we may be asked to just take a look at their eyes and see what their baseline vision is. And this woman had a hemicentral vein occlusion, and then also had Hollenhorst plaques like just outside the disc in the on the opposite side. So this was a inferior hemicentral vein occlusion, and then Hollenhorst plaques right outside the disc. And I took a video of it because I hadn't seen something like that before. But you know, how often is that found together? And then is there any additional counseling you give to a patient that has such findings?
That's a great question. Yeah, I would consider those two findings to be unrelated, except to say that the common thread in that patient is suspected underlying arterial sclerosis, because arterial sclerosis is a major risk factor for both of those. So number one, she probably has carotid occlusive disease, maybe cardiac valvular disease. So that would have to be checked into for the plaque. And then for the vein occlusion, I don't think the finding of the plaque of the Hollenhorst plaque would modify my standard management of the vein occlusion. Does that help?
Mm-hmm. Thank you, sir.
Does anybody else have any comments on that? Yes, thank you. Anybody want to comment on that situation? All right, let's see how are we coming along. My timer's looking pretty good. So let's talk about arterial.
Dr. Pautler? Sorry,
yes, thanks,
it's Ashley. I have a quick comment about the treatment of neovascular glaucoma in these patients. The residents might notice that these patients, especially maybe the indigent patients, might come in with very late stage of glaucoma, or you know, they might have a hyphema. Their pressures might be very high, and when treating these patients, it might be hard to give them the full 0.05 cc's of anti-VEGF. And I just wanted to mention that sometimes it's not entirely necessary to give the full dose. And that because oftentimes you then have to do an AC tap and then they bleed more, then the view for PRP is oftentimes obscured. So I think what I always tried to do is if you can get the PRP in that day before you give the VEGF, if at least you can start, it's helpful. And then don't always have to give a full dose in order to not jack up the pressure so much that you need a big AC tap, which causes more bleeding. Just as a tip for the residents.
Yeah, great points, great points. Thank you for that. I agree.
What about tapping?
So let's talk about, yes, go ahead.
What
Please
about,
go ahead.
what about tapping before injecting? Is that something that's ever done?
That, yeah, I often do that. I often will tap. It is true there's a risk of bleeding in the anterior chamber. I've been fortunate not to have had that, and I only removed just enough fluid to get by, but that is a potential risk. But I think Dr. Crane's comments are well taken. Before you do anything, if you can start. The other thing you could do in a case like that is to get in your laser, get in your injection, and then do the tap. But I tend to tap before I inject.
Scott, that was a wonderful talk. I have one question about management of ischemic CRVOs, and this is something that I do without a ton of evidence. There are only case reports which have steered my management with this. In some cases of ischemic CRVO, meaning an afferent defect, a swollen appearing nerve, and the appearance of diffuse phlebitis-like picture on presenting angiography, I'll often give an anti-angiogenic on the day of presentation, and a week later give a planned single dose of intraocular steroid, like a triamcinolone or an Ozurdex, because there are case reports where patients have done well with that, although there's no randomized controlled trial to validate that that's a superior treatment plan. Is that something that you or anybody else on the call does for the more severe or clinically ischemic central retinal vascular occlusions? The venous occlusion.
Anybody? Yes. Anybody?
I don't typically do a steroid so early. I always worry about the possibility of glaucoma in those patients. So I typically will start with anti-VEGF therapy. And I usually will add a steroid if I can't extend their treatments too much, or they're having difficulty come in, or they're not responsive to anti-VEGF, then I'll tend to use a steroid. If the glaucoma, if they have glaucoma that's controlled.
I tend to mirror Karina's, Dr. Finlay's management, but I think there's a lot of leeway here for management in these difficult cases for sure. So that I don't get in trouble, I'm gonna, wait a minute, I have a text. Okay, thanks, Steve. I was checking my timer, trying to stay at 45 minutes. I got an assurance that that's okay. So thank you, keep the questions coming. I'll get started on arterial occlusive disease. So cotton wool patches, we'll start with those. Occasionally you'll see patients who come in with one or more isolated cotton wool spots. Cotton wool spots are seen in a number of different disorders, and sometimes they're associated with other retinal findings that clue you into the cause. But at other times you see them in an isolated situation. As you know, they represent acute obstruction of the radial peripapillary network, the pre-capillary arterioles. And so you get an infarct of the nerve fiber layer. Your book says less than 1/4 disc area, but they can be larger than that. They may or may not be symptomatic. Now and then you'll have a patient coming in with an arcuate scotoma, and you'll find an isolated cotton wool patch as the cause. It takes a month or two to fade, takes longer in diabetes, and can present with a diagnostic dilemma. The underlying causes are widespread, and so history is going to be very important. If you have a young patient, you might think, well, is this HIV? If you have an older patient, you might wonder, is this the beginning of giant cell arteritis, a vasculitis? History can be very helpful. Associated findings can be helpful. In this picture down here, it looks kind of like there's quadrantic retinal hemorrhages. you have a few cotton wool patches that are fading. This isn't so problematic. It's a vein occlusion. But here you have a patient who just has this isolated cotton wool patch, and it could be any number of problems. And often you'll do a workup and you won't find any cause, and they just go away on their own, and that's the end of it. But you need to be aware of there's a host of causes, doing a careful review of systems. And I think in most of these cases, at least a limited workup, I think, is in order. That topic came up a couple months ago with Dr. Cohen, and I thought about it, and I thought, well, most of these cases, I do some sort of workup, unless I know what it is. If they've had a radiation or something, that I don't necessarily work them up. I need some help from a second-year resident. What is that?
Myelinated nerve fiber?
Yeah.
That's exactly right, Sarah. Thank you. First years, do you know what this is? Any first years have any questions about that? Not a question. Good. That's exactly right. The myelinated nerve fiber layers are much wider than cotton wool patches. They're asymptomatic. It looks awful, but they're asymptomatic, and it's just important. Now and then you'll get them, and you'll have somebody refer to you, and maybe an optometrist, and they're confusing them for cotton wool patches and such as that. So I put that in there for fun. So let's skip over to retinal artery occlusions. Retinal artery occlusions, for the most part, are caused by emboli as opposed to vein occlusions, emboli. And you first thing you want to do is to determine the location of the embolic occlusion. Is it ophthalmic? Is it central retinal, branch, cilioretinal? You can usually tell this by location and other findings. You want to identify and treat any underlying causes. And the ocular treatment for an acute occlusion for patients with central artery occlusion is to lower the intraocular pressure. For branch artery occlusion, the prognosis is so positive that rarely do people go through Diamox, ocular massage, paracentesis for branch artery occlusion. But that is done often in central artery occlusion. That we don't know how effective it is, but it's one of the few things you can do that may help. Over the years I've done paracentesis, I have had a significant minority of patients who've done well quickly within a day or so after my tap, and I've thought it might have been related to the tap, but you just don't know for sure in these cases, but that's often done. You want to follow for sequela, even in artery occlusion. Yes, please.
Sorry to interrupt you. Are you doing the tap if you see the plaque or anything, or are you just doing it regardless?
That's a great question. I think if you see a plaque, that would be a stronger indication, but very often in central artery occlusions, you don't see the plaque, but there's a plaque there. And that wouldn't, if I didn't see the plaque, that wouldn't preclude me from doing a paracentesis. But if you see one, certainly that's more indicative. If I don't see a plaque, I question them even more about giant cell arteritis. And if I have a patient who I think has giant cell arteritis based on history, I won't do a tap. I send them right to the ER, get the Ceterate, to get them started on steroids, and make arrangements for a temporal artery biopsy. Great question.
Thank you.
So you're looking for, iris neovascularization after artery occlusion is not common, but it can occur, particularly if the patient has diabetes. They have other microvascular disease, and it usually occurs within 3 months. So don't turn your back on these patients. We'll follow them as well. And then, of course, the nuance here in the last 5 to 8 years is that they're at high risk of subsequent stroke. And for the most part, you want to send them to the emergency room to get a stroke workup when you see this, and any artery occlusion. Now, here is a cilio-retinal artery occlusion. We saw an example of that in central vein occlusion, but here's just an isolated cilio-retinal artery occlusion. It arises from the posterior ciliary arteries, and this is important. The artery arises from the posterior ciliary arteries, not the central retinal artery. So if you have a branch artery occlusion, you don't think of giant cell arteritis. If you have a cilio-retinal artery, you've got to consider giant cell arteritis. And I think that's an important point. So etiology. We keep talking about embolization. You can get thrombosis, a primary or a secondary thrombosis in the retinal artery. That's usually seen in people who have inflammation, toxoplasma, such as that. For the most part, it's an embolus, cholesterol, platelet fibrin, calcific. And so you have to think about the heart, endocarditis, or more likely heart pathology, maybe calcific valvular disease. Coagulation disorders can be seen in artery occlusions, but it's not very common. And I generally don't work up people for coagulation disorders unless they're young, like the vein occlusion patients. But trauma has been implicated, connective tissue disorders with lupus anticoagulant, giant cell arteritis, we've mentioned that, particularly in cilio-retinal and central retinal artery occlusions. Again, if you have a localized area of retinitis, you can get a secondary artery or vein occlusion for that matter. And then this is, I think, pretty important, because if you have a young patient who has an artery occlusion, something's really wrong here. You've got to look further. Do they have any neck pain? Have they been in an auto accident? Did they bump their neck with the seatbelt and such as that? Sorry. And so have a high index of suspicion for carotid dissection or order them for testing. Fibromuscular dysplasia can be seen in young people and present as a type of complication like carotid occlusive disease. And lastly, a patent foramen ovale is seen in 10 to 20% of patients. And so you can get a blood clot in the venous tree that gets into the arterial tree through the was listed in your book. I think that's pretty rare. So first or second year, what have we got here? Just describe the picture for me, please.
Looks like you've got some retinal whitening of the macula, center of the macula, the fovea involved, with a little sparing, likely the area of distribution of the cilio-retinal artery there. Yeah.
Yeah, we're beating the cilio-retinal artery to death. You're exactly right. Good pick up there. Maybe a cotton wool patch over there. And notice most of the ischemic whitening is in the macula, but see over here, you still see it out here as well. There's some ischemic whitening of the retina. And so this is typical central retinal artery. If you have somebody that comes in real acutely with central artery occlusion, that the whitening may be very subtle. So you have to have a high index of suspicion based on acute amaurosis, Fujax and such. Good. So let's talk just briefly about paracentral middle maculopathy, or PAM. It is not a disease, so that's not the diagnosis. PAM is just something that you see in a number of vascular diseases, and it's best detected on OCT. It was originally described as a type of acute macular neuroretinopathy, but it's subsequently separated. So let's look at our layers. Here you have a little bit of a slightly dark band here, the ganglion cell. Here you have the internuclear layer, and here you have the outer nuclear layer. Right in the middle, you see the internuclear layer. On the inside edge is the intermediate capillary plexus, and then in the outer edge of it, you have the deep capillary plexus. So when you have deep capillary occlusion, you're going to get opacification of the internuclear layer, and it can be in diabetes, vein occlusion, any number of diseases. I stuck this slide in here just for illustration, because they're sometimes confused because they were initially described together. PAM is the middle, it's the internuclear layer. Here you're getting shadowing, just shadowing, but the whitening is in the middle layer, the middle of the retina, the internuclear. Acute macular neuroretinitis, here's your middle layer here, it's fine. It's the outer nuclear, and for that matter, some of the outer bands as well. So this is acute macular neuroretinopathy. This is PAM, two separate entities. Any questions before I move on? All right. So let's talk about ocular ischemic syndrome. Now keep in mind, this is a chronic hypoperfusion. It's not an acute thing. So these patients are going to come in and they're not going to say, yesterday I noticed this or that. For the most part, they're going to have sort of diffuse chronic symptoms. And it's due to hypoperfusion from an occlusion of the carotid or ophthalmic artery. They have a gradual loss of vision. They may have some aching pain. They might describe slow light recovery. Their vision may not be awful, but it could be down fairly significantly as well. Now, the tip-off here is you're going to find deep retinal, which basically means large, dark blot hemorrhages in the periphery, often temporally, but they can be 360. And they can be bilateral, but it's usually one eye. And so if you have a patient that has a picture like that where you're thinking, oh, I'm thinking a central vein occlusion, but you say, well, gosh, the veins aren't particularly dilated. There's no disc edema. There are these just big blot hemorrhages out in the periphery. Think of ocular ischemic syndrome. If you have a diabetic that has primarily peripheral pathology and it's asymmetric, think of possible ocular ischemic syndrome and order a carotid sonogram. The interesting thing about these patients is they may have iris or angle new vessels, and yet their pressure might be just fine because of poor perfusion of the ciliary body. But of course, if they get treatment, endotherectomy, the pressure can just jump up sky high. So you have to be prepared for that. Ophthalmodynamometry. We all do this every day, probably 3 or 4 times a day, right? No, of course not. Nobody, have the residents ever seen an ophthalmic dynamometer?
Never.
Okay, and you're not alone. So there used to be this machine you would press on the eye. You'd see how far you could press on the eye to close the artery, and then there'd be a little gauge, and you could say how much pressure it took to close the artery. Now, what you can do is a finger ophthalmodynamometry, and basically through the eyelid, just press gently on the eye as you're looking at the central artery. And if you can close the central artery by pressing on the eye, then that's a high indicator of ocular ischemic syndrome. It's a real quick and easy thing to do to confirm your diagnosis. Usually you don't need that. All these other findings tell you, but it's something that was in your book, so I put it in. So this is a case of mine of ocular ischemic syndrome. This iris was what I like Dr. Eichenbaum's term for this. I've adopted it. This is a surgical iris, in case you want to know. So here we have a surgical iris. And this, you can't see it too well, but there's rubeosis. This patient had normal pressure, and here's the right eye. It was the right eye that was affected. Now, why have I shown you a picture of the left eye right next? Same magnification, by the way. Here's the right eye, here's the left eye. What's the difference? It's subtle.
The artery isn't as evident, and then there's a peripapillary atrophy as well. To the right.
You're right. There is the peripapillary atrophy, but you're exactly right. Yeah. Look at the size of the arterioles. You can see the arteriole there. Look at that little tiny thread, little arterioles. That's real typical in ocular ischemic syndrome. Now, this patient did have some peripheral hemorrhages. Here's one here. There were more peripheral. I couldn't capture them with that camera at the time, but this is the vessel attenuation, peripheral blot hemorrhages were there. The fluorescein showed this fern-like feathering, all this capillary dropout from the ocular ischemic syndrome. So the underlying cause most commonly is arterial sclerosis, by and far. I've never seen a patient with Eisenmenger syndrome, but you can get a right to left shunt due to ventricular septal defects, pulmonary hypertension, and they get hypoperfusion. Has anybody seen an Eisenmenger causing this? I've not. Yeah. Well, the other thing you can think of, it would be pretty rare, but giant cell arteritis could conceivably cause this. The problem is this is sort of a chronic problem. And by the time giant cell arteritis would cause ocular ischemic syndrome coming on slowly like this, I would expect you could have seen a lot of other pathology for the giant cell arteritis, but it was listed. How do you treat it? Well, if it's not a complete occlusion, of course, you send them out for endotherectomy. Keep in mind that if their angle is zipped up, you're going to have a pressure spike, so you got to plan for that. Anti-VEGF can be real helpful in these patients to resolve the iris new vessels quickly. The idea being is that if there is any open angle, if you can stop the new vessels and preserve a couple hours of angle before the PRP laser kicks in, all the better. If the angle's already zipped up, I wouldn't feel so compelled to give anti-VEGF, but I would do PRP just to stop the progression of the angled new vessels, dry up the iris a little bit, so that because these people are going to require probably a ceton, and you'll avoid a lot of problems with hyphema and such as that at the time of surgery if the angled new vessels are occluded or closed, and the angled new vessels won't occlude the tip of the ceton in these patients. So PRP is needed, even though you don't expect to get an improvement in the vision. Macroaneurysm, a focal ectasia, meaning dilation of the retinal arteriole, maybe multiple or bilateral. They're usually unilateral though. And it's seen, especially in women, elderly women for some reason, with long-standing hypertension. Sometimes at the site of the macroaneurysm, you can look back on your pictures and you can see where there was an embolus that damaged the vessel wall, which then evolved into a macroaneurysm. But most of the time, you'll just see the macroaneurysm. Often you'll see the macroaneurysm just sitting there causing no problems at all. At other times, it's causing symptomatic loss of vision. The most common cause of loss of vision is chronic edema and exudates, as in this patient here, extending into the fovea. Acutely, though, they can bleed. And there's a little bit of blood here, but that's asymptomatic. Sometimes you'll get a big subretinal hemorrhage, and it looks like macular degeneration. And then you'll do a fluorescein, or you'll look carefully at the arterial, and you'll say, oh, there's a macroaneurysm causing that. The hemorrhages from the macroaneurysms are unique because they could be subretinal, intraretinal, sub-ILM, and vitreous. So you could have different levels of hemorrhage. So if you see somebody who has subretinal, intraretinal, preretinal, and/or maybe vitreous hemorrhage, and you can't see anything else, you could say, well, this is very likely going to be an underlying macroaneurysm. And as the vitreous hemorrhage clears, you're going to be able to identify it and treat it. All right. An occlusion of the distal arterial is exceedingly rare. It was listed in your book. That's exceedingly rare. In the past, it was reported when we used to use a yellow dye laser with that, but on its own, that's rare. So here we go. Upper left side, you have a little macroaneurysm, a little associated hemorrhage, no exudates, really no symptoms at all. The fluorescein angiogram shows the macroaneurysm. This patient could be observed. There's nothing you have to do. You want to be sure their blood pressure is managed, but there's nothing you have to do for the macroaneurysm. Here's one up here. It's hard to say where it is, right there. The circinate exudates, and then a larger band of circinate exudates into the fovea. That's not good when the exudates get into the fovea because there's often permanent retinal damage. But that one you would certainly treat. How do you treat it? Well, again, manage the hypertension and look for other causes of atherosclerosis that are treatable. If they're asymptomatic, just observe them. Nothing has to be done. If you have edema, consider focal laser. There's a trend, it seems to me, among younger retinal specialists to go to anti-VEGFs, and I don't think that's necessary for most of these patients, except to say sometimes I'll try to dry up their macula quicker with anti-VEGF, but then as soon as I do that, I get the laser in, because the laser to me is a much more definitive therapy for this. So focal laser with or without anti-VEGF, depending upon the clinical presentation. And the book, your book talks about treating around the macroaneurysm as opposed to on it. And you don't want to blast it, but generally a light, medium-sized spot size on the macroaneurysm, unless you have a lot of perianeurysmal ectasia of the capillary bed. Unless you have that, it makes more sense to treat the source of the leak, to me. And I've gotten good results, and I've seen no complications with that. So if you have a hemorrhage now, if it's a vitreous hemorrhage and it clears, no treatment needed. No treatment needed because once a hemorrhage occurs like that due to a macroaneurysm, they usually scar down and don't bleed again. So if it's bled and there's no macular edema, you can just watch them. Nothing needs to be done. A non-clearing vitreous hemorrhage, vitrectomy can be helpful just to clear the hemorrhage out and get the vision back quicker if the patient's impatient and you don't know what's going on especially. Submacular hemorrhage can be a real problem, and I don't think there's a really good answer for that. You can observe them. I suppose some people might give anti-VEGF until the hemorrhage clears. You could try pneumatic displacement, vitrectomy with TPA. There's no good answer for submacular hemorrhage, I think. Oh, well, how did I do? I'm a little beyond my time. Thank you for your attention. Any questions on any of the topics that we've covered?